The living donor advocate is a sort of new role that's mandated by UNOS, sort of came out of a few living donors were lost along the line. And so I am, as Carrie said, I was part of the team. I'm not part of the team anymore. In fact, I'm retired. And the biggest part, as UNOS is concerned, is that I have no input in who gets a transplant. Everything I learn about the recipient, pretty much, is from the donor. And I'm not going to flip through these things. I'm not going to talk like that. I think the basic thing that I tell people when I meet them twice. If the evaluation goes through, I see them in the hospital post-operatively. I'm supposed to go over like everything that goes on with their whole evaluation, pre-op, post-op, the whole shebangus. I individualize that to some degree, as Dr. Tedla individualizes his medical evaluation. I sit down after taking demographics, I sit down with the donor and say, my concern is you. You're the only person I care about. I want to make sure that you know what you're doing, that you understand, that you want to do what you're doing, that you're not feeling coerced in any way, and that you know that you can get out of it. If you decide you don't want to do it, give me a call, let me know. I give them my phone number, and that's the end of it. That has happened a couple times, and it's there's a whole grievance policy in the policy manual. I've never had to grieve if I tell the team this is not a donor, it's not a donor. I will say that I work a lot of times carefully with, in close contact with Susan, especially the patients that we questioned about. I do ask the patient why they're doing it, and that gets the whole ball rolling, and we talk about everything. And I think I'll cut it. And if anybody has any questions.
You're allowed to talk from more than one slide.
Well, I have, you've got them, look at them.
Leslie?
Yeah.
You said you had a couple of patients that, or a couple of donors that said no, eventually said no. What were the reasons given for that? Can you share that with us?
One felt that they were really being pushed, and they really didn't want to do it. Another one was a complicated case with the recipient, and that there was no real person to help the recipient, and this was the donor was the daughter, so there was more input. So, like, and she just decided that she wasn't going to give her kidney that was probably not going to last very long because the recipient couldn't take care of it. But that was basically it. I did have one donor said, when I said I can get you out of it, said to me, what do you look for that you say I'm okay to donate? And I said, well, I really don't do that, but I do, and that's in the slides too. A lot of what I get is their questions, their eye contact with me. Do they talk to me? Do they hide? I had one donor, the one time I said, you know this isn't going to last forever, and the shut down immediately. It was like, then why the frig am I doing this? But it took a little while, and then he came around. So it's sort of interesting how we all find out different things.
Leslie, if someone, a potential donor doesn't want to give, but doesn't want to tell the family they don't want to give, what is the explanation given?
It depends upon the whole thing, what's going on. A lot of times there is something medical there, there is something there. It's never, he doesn't, he can't do it. With sort of, they go a little on that HIPAA stuff. It's we can't tell you because of HIPAA. And I've never, like, the people that have said no, that we have said no to the recipient, I've had no recourse from the donor that, they came back on me.
The donor team is completely separate from the recipient team except Susan, because we just don't have enough experienced social workers to have a separate donor team. So we don't kind of cross paths until after transplant. That gives us some firewall. And we just say they cannot be a donor, we cannot tell you because it's their business. And the ones who generally are going to back out for one thing or another usually maintain that wall long enough for us to get away with it. The ones close enough between themselves, they usually want to donate anyway, so they're already sharing their information.
And just to piggyback on some of the things they're saying, I do have both of them. I work as a recipient coordinator and as a donor coordinator. And we've had some of the recipients and donors who are really not compatible, who are adamant that they want to give a kidney. And so they will reject our center and go to another center, not telling the other center what's going on with them at Downstate, to try to see if the other center will bypass what's going on with them and transplant their donor.
There's a lot of variation among centers when it comes to recipient suitability. There's not quite as much variation about donor suitability. Donor safety obviously is paramount. What some other centers do that we have not yet initiated, whereas what Dr. Tedla was talking about before, paired kidney donation and some of the more aggressive desensitization protocols. But we're on the path to get there. We actually are registered as a paired donation program, and we're starting to work with some of the members of the lab to put some people in. We just haven't gotten there yet.
Now, the medical stuff is kind of the easy part. And both for recipients and donors, the harder part is the social and psychosocial aspect. I'm going to give you a case, and everybody here is transplant, so it's very easy answer. A middle-aged donor donating to a middle-aged sister, cause of kidney disease, polycystic kidney disease, the donor is healthy by all things we do. Should you accept the donor or not? I'm stating this as a way to show you when things get ambiguous. So it's kind of a way to illustrate the easy case so we can have the difficult ones down the line. There are kind of three things we consider when you're doing donor evaluation. The first thing is it safe for the donor? The second is the harder part that everybody is involved in, and we kind of work together because, as we said earlier, one person gets one piece of the information, the other gets another piece, and we kind of piece it together at the end. But the other thing also is patients, as they go through the process and they learn something from us and they reflect on it and they give us maybe better information down the line. So through iteration, in a way, we get kind of to the crux of the matter eventually, but it may not be that easy. The third thing is, in a way, majority of the time, the donor and the recipient know each other, and they're coming saying, okay, I want to do this for my recipient. How much of that, the recipient side of the story, should they be aware? Leslie just told us that one of the donors, potential donors, balked when they realized the kidney is not going to last forever. But what if the recipient has more serious conditions? How much of it are they entitled to know? So these are kind of the things we grapple with when we're doing live donor evaluation. And for the medical side of things, we want to assess risk of surgery, risk of anesthesia. Do they have two kidneys? We expect that they would lose about 30% of their kidney function permanently. We know by and large it's not harmful, but they have to be aware of this, whether it is a risk for end-stage kidney disease. I will show you a few slides just to briefly to go over it, because UNOS and CMS mandate that we discuss this, and the information that's out there, some of the research is fairly controversial, and you have to put it in the right context to pass the raw information, but put it in context. That's not going to be easy. And the other testing we do is, is there a risk of transmitting something from the donor to the recipient, infection or cancer? So those are the tests we do. I mean, they have normal health, and do they have 2 kidneys? Could they transmit something from the donor to the recipient? And when they do have 2 kidneys, sometimes one kidney only could be affected and the other may be okay. And you may not know this in a person because one kidney is good enough for healthy survival. And even for a kidney function would completely look normal if you are born with just 1 kidney. And it's not as rare as you think to be born with 1 kidney. About 1 in 800 to about 1 in 1,000. Imagine you have about 350 million people. So if you have 1 in 800 or 1 in 1,000 person born with 1 kidney, you're talking about millions of people who are walking around with 1 kidney. And the test would not show it unless you look with imaging for a kidney. So if you have 1 kidney, it's obvious you cannot be a donor. But if you have 2 kidneys and 1 kidney looks somewhat showing you something, let's say you have a cyst, you have a kidney stone, one looks smaller than the other and not by a whole lot smaller, what are you going to do? Those are the other thing that you look at. And now, these are the more straightforward things. Now, what about you don't have a kidney disease, everything is okay, but you have a risk factor for kidney disease. You are obese, you have high blood pressure or borderline blood pressure, what do you do? And we can get even 1 or 2 or 3 steps removed. You don't have any of these, but you have a family history of a kidney risk factor for a kidney disease. Somebody in your family a grandmother has diabetes. Your parents have diabetes, or they have high blood pressure or have kidney disease. These are the ones that are harder to deal with. They're not exactly clear contraindications, so we have to individualize. We cannot get into the nitty-gritty of this, but just to show you the complexity of donor evaluation. And just like risk factors could be shared, the disease conditions could be shared. One of our potential donors came in with identical, potential recipients came in with an identical twin potential donor. And the problem is the disease the recipient has a high likelihood of being developing in the family member. And you have an identical donor. For the recipient, that would be probably as good as it gets, but for the donor, that's a good thing. We decided after doing a bunch of things not to go ahead, and it's fortunate that we did because that person down the line developed the kidney condition himself. So this is the obvious, but a lot of the conditions that recipients have doesn't happen in all family members. Maybe a 20% risk, maybe a 10% risk. And even that, even if you do develop it, let's give an example of diabetes. Diabetes, the chance somebody who has 2 parents who has diabetes, who have diabetes would have a child who would eventually develop diabetes close to 80%. So majority of people who have 2 parents with diabetes would have diabetes. But the chance of somebody having kidney failure from diabetes is only about 50-50. You can have diabetes all your life, you may not end up having kidney failure. So by the time you go through all this and you make the donor understand, the motivation of the donor makes a big difference, because if you are going to take a risk, it should be for somebody you really are going to take that risk for. The rest of them would usually be stop the evaluation at some point. The free of coercion is a little tricky. One, because people tell you what you want to hear. The other thing is people have relationships, and how much leverage is coercion? If a spouse wants to donate to the breadwinner of the family, is that coercion or is that really self-interest? And how can you really tease that apart? And all donors are taking risk. I mean, they have absolutely nothing to gain from this physically. They have some risk, including risk of death from donating, and how much risk is considered acceptable, and who is to judge. So if you are a parent and the house is on fire and you run into the house to get your child out, is that really acceptable behavior? You have a chance of dying, and a good chance if it is a raging fire. And if you don't, is that neglect of a child? Now imagine the same situation where you have now a parent, there's no way the child could get, a young child could get a kidney transplant except from that donor who is a parent. Should you deny that? What risk is acceptable to them? If they say, it doesn't matter to me, maybe on dialysis in 15 years, I'm okay with that. I want my child to grow up and have a life. Should we turn that down? I'm giving you an extreme example just to show you how complicated it could get. There is even some discussion in transplant circles about whether we're doing harm by turning a potential donor down. Not like you have one kidney and we're taking one kidney out and you're going to go on dialysis kind of risk, but you're taking some risk, and it's considered kind of little higher than usual risk. If you turn that person down and there is a strong emotional attachment to the potential recipient, are you actually harming that person? I'm not saying there is a good answer for this or it's even a good discussion, but this discussion is happening. Donor evaluation, whether they can give up the kidney or not, is not really the question. That's easy to answer in most situations. The biggest problem is, what is the long-term risk? A lot of it is known, some of it is not known. And the other thing is, how much risk is acceptable to us or to the recipient or to the donor. Some family would come and say, there's no way I'm going to take a kidney from my children even though they're asking me, because I'm 65-year-old, I have a 40-something-year-old child, but I have lived my life, leave me alone. I don't want to take it from them. Is that a good answer? And what are you going to tell them? Some of it is not being well informed, but a lot of it is just not taking that risk. So donor evaluation is complex, not because whether some kidney donation is safe or not is in question. It is complex because the social context is very, very complex. I'm going to quickly go through the risk of ESRD and survival information, because those are the two things that we are mandated to share with donors, and I want the people in transplant be very familiar with the information we're giving out. This is just to show that kidney transplant, live donor transplant, is the most common transplant worldwide. In the US it's not, because we have deceased donors, but the rest is the reverse. And a lot of the problem we have about knowing how risky is a kidney donation is because we don't have anybody to compare kidney donors to. These are the healthiest of the bunch. They are the most investigated group. And to say, oh, because we have compared this to the general population and they do well, is not really a fair comparison. So keep that in mind. But we have very solid information when it comes to live kidney donation. Live other organ donation is a different story. So one is, if a donor comes and says, by donating a kidney, am I at risk of dying sooner? Am I going to live a shorter life? And the answer to that is, if you survive the surgery, you have a normal life. You're going to live as long or longer than anybody of about the same health. We know that because if you compare to fairly well-matched controls, donors live, this is mortality, so mortality is lower than in donors than non-donors. Now there's one, Dr. Grussler mentioned this statistic. He said 1 in 8,000 is probably the more accurate than what's published of about 3 per 10,000, because this was around the time when that clip that's off the market was around, and some of the donor death happened around that time. So if the donor is going to die, if the surgery is done in good hands, then it's either bleeding or he had some injury of internal organ, or it's a pulmonary embolism. Of these, the two that we can have control over are the technical ones and also OPE. So nursing is very important, get them off, get them around. And if there is a chance for bleeding, you have to catch it early so the surgeon can save the patient's life. Now, this study came out of Norway, and what it showed was that mortality is higher, not by a whole lot, but you're talking about 25 mortality for the controls is about a little over than 10%, and for the donors it is about 16% or something. But it's a very tiny number, so it looks 16% is of a small number, so you're talking about 2-3 people when you look at these things eventually. And this made a big headline and saying that donors die at a higher frequency. And the problem with that is this. The donors were older than their comparator group. And if you already start with an older group and you follow them very closely, they're going to have more deaths among the older group than the younger group. So the jury is not, the decision is not really settled. And everybody in transplant and probably outside transplant believes this statistic is not showing the truth. It is kind of flawed in design. You have to be aware of it so you can answer this point. And this is just US Census data. If you take any 38-year-old, like this group, the control, and this is a 46-year-old group, and you just follow them 20-something years, obviously the older group would have higher death, and about the same magnitude. That's one. The second is kidney failure, and this is hypertension and I'll show you first the this is proteinuria. How much? I mean, we use proteinuria as a measure of kidney disease, whether donors develop kidney disease. There's one study that is ongoing, and this is the 3-year data. They have donors and similar controls, and they're following them. And what we have is here, GFR, you expect it to go down. You lost a kidney. And the proteinuria is exactly the same. There is no difference. At least in 3 years, donors do not develop proteinuria. If you go to longer-term literature, there is a slight increase in proteinuria, but the amount of protein you're seeing in the kidneys is a tiny amount. Compared to controls, it goes about by 50 milligrams. So normal people have about 150 milligrams of protein in a day, and if you add 50 milligrams more, it's not really the end of the world. So it is more a lab value abnormality than a real abnormality. That's my point. It doesn't mean that some people do not develop kidney failure. They do. How many? We have about 200-something that have been reported in the United States since about the 80s when UNO started collecting data. So this is out of about 100 and something thousand live donors. So there are people who develop kidney failure after donation. What do they develop kidney failure from? About half develop from hypertension and diabetes, usually several decades afterwards. The problem is you wouldn't know whether these people would develop diabetes or hypertension because most of them are healthy and all the tests look normal at that time. The other half usually develop kidney failure a little earlier, and those are the ones who usually have potentially heritable conditions or familial conditions as they can share. Now, the ESRD information, again, this paper, again, made headlines about 4 years ago, and it is part of the reason why UNOS is now mandating that we tell donors that there is increased risk of ESRD after donation. Now, what they did was they took all potential donors and all donors from UNOS, and they compared it to data from NHANES. This is a national survey done by the federal government, the CDC, and it's a nationally representative sample of adults. They took samples from there, and they tried to see what the difference is between donors and non-donors. And at 15 years after donation, or 15 years from the time those patients surveyed had follow-up, they found out that donors had about 30 per 10,000. So about 0.03% or so. And and then you have the controls have about 4. And if you look at the relative risk, meaning if you divide this by this, almost like 8 or 9% times more. But it's 8 or 9 times more of a very tiny number. So it's still well under 1% at 15 years. So a majority, more than 99% of donors do not develop kidney failure. And this is the reason why we're telling people that they have increased risk of kidney donation, kidney failure. What I tell potential donors is, one, majority of donors, overwhelming majority, do not develop kidney failure. Two, there is information that there is increased risk in some donors. We do not know which one, but if we have to guess who they're going to be, these are usually people who have family conditions that could be shared between family members. And then if that is pertinent to that specific donor-recipient pair, we go into the details of that condition. Somebody has, let's say, diabetes, then we'd go into how likely are you going to develop diabetes, how likely are you going to develop kidney disease from diabetes, and is this something you want to take? If it's not applicable to them, just give them the general information. The other information is what is reported again from Norway. Again, the problem from the Norway study is these are people who are blood relatives, and almost all the people who develop kidney failure happen to have glomerular disease, kidney diseases that are potentially shared with families. There is a calculator that is now online and available. It's based on similar analysis, and it puts in values that are available to you, blood pressure and creatinine and age and a few other things. And it gives you the 15% and lifetime risk of having kidney failure after transplant. Almost always it is going to be low. But it's kind of reassuring for somebody to have a number to look at. So if that's what you want to show the person, it's something to look at. I don't think it is that helpful because you could have that estimate by yourself anyway most of the time. But again, UNOS is harping on this, and they want even this to be part of the discussion. If you want to make it part of the discussion, okay. This is what you would get if you use this. And you see that most people are here, African Americans, donors tend to have a higher risk. But the baseline risk of kidney failure among African Americans is about 3 to 4 times higher anyway. So whether donation has anything to do with it or not is the big unanswered question. I think the biggest factor to think of is age. If you look at risk of, again, this is predicted lifetime risk. So if you donated at 20, your chance of having kidney failure over the rest of your life may be higher than if you donated lower, because you're probably going to die before you develop kidney failure. This doesn't mean that donation is going to make you lose your kidney function and end up on kidney failure, but you probably have 40, 50, 60 years of life left where you could develop something else. So I think the biggest care we have to do is for people who are young and coming as donors. It doesn't mean that they cannot be donors, but they should be mature. That's where social work and independent living advocates come in. And you really have to make judgment about their potential history. And if there is a potential donor who is more middle-aged, I think we should go for the middle-aged donor. That gives you a nice middle ground between a very good kidney function for the recipient, kind of time-tested donor that probably has passed the stage where you would see some of the indications of a chronic disease developing, and be very careful with young, especially African American donors. And 85% of our list is black. So for us, this is big. We really have to be careful about people with little things here and there in the family history. I think with that, I'll finish.
That's a very good slide. That previous slide.
It's good, and you have to put it in context. Remember, it's not 100%. The lifetime risk of an African American at the age of 20 donating and having kidney failure is 1.6%. This is the estimate, which means 98% of the people would not have kidney failure. That is, I mean, still a personal decision. The donor has to decide whether that is something that they would like to take a risk or not. A lot of times, and all of you who have done donors, let me know. I haven't seen, let's say, a 26-year-old parent donating to their child, or in their 10s, and kind of young people saying, oh, I'm not. You tell them and they listen to you, they say they nod, and they say, I'm going to go ahead and do it anyway. So it is more for information purposes than really to change their decision, because the ones who have strong emotional bond would go ahead knowing this risk. It matters for the ones who are coming, who say, I remember one of our, you know who, we have a bunch of donors who came for one person, and the moment you talk about this risk, they have a whole bunch of people who are walking out. So it focuses the discussion, and they should have this information. I don't want you to walk away with the information with a perception that kidney donation is such a risky thing as far as developing kidney failure is concerned, that it is not a good idea to donate. But you have to go with your eyes open. You could still die from living donation on the table or the next day, if not from non-bleeding, from pulmonary embolism. So it is a serious matter. Or you can have an anesthesia reaction and die from it. But giving up one kidney is not really. We have 70 years of information on this. We have 1 out of 1,000 people who are walking around with one kidney doing pretty much normal. So whether you should donate and have problem from your losing one kidney, I don't think that's a big issue. Whether you have problems from donating a liver, donating a lung, that's a different matter. But kidney, I think, is fairly well settled.
Do transplant centers track their donors long term? I mean, is that required by UNOS or anything, or is there any trend? Because you're saying you have 70 years of experience, but how much do we really know? I mean, is it reported? Are they all reported for over 20, 30 years?
We are mandated, and this is a mandate that happened over a few years ago, to follow them and report for 2 years. So there's no long-term follow-up. In the U.S., the U.S. organ allocation rules give you priority if you have been a donor and develop ESRD. So a lot of this information is coming because when they go on ESRD, when they develop ESRD and they get on the wait list, they're going to claim that extra credit, and you can identify previous donors through that. So there's probably some people who have not reported that, or their kidney disease has not gone far enough to require dialysis or transplant, so they're not on the wait list, and they may have developed kidney disease and we don't know about it. So this is probably an underestimate. But from whatever is known, kidney donation by and large is safe. And I think you have to give the donor the best information you know. And this is general information, not just the general information, the best specific information for that recipient. As I said before, if you have 2 parents who are diabetic, and one of them already developed end-stage renal disease, the best predictor of a diabetic person, whether they develop kidney failure or not, is whether they have a family member who has developed kidney failure. So that is kind of, more than the other diseases, the most worried I am are the people who are young, who have strong family history of diabetes, and are coming to donate and everything looks okay. because those are the ones who most likely would develop diabetes and kidney failure down the line. What we do not know is whether having one kidney or two kidney makes a difference. Kind of think that it makes a difference, and we will tell them that may be the case, but we do not know. They could still end up having kidney failure with one kidney or with two kidneys anyway.
There's actually a HRSA pilot, because that's always been a very large criticism from the transplant community, is that, you know, you as a transplant center are expected to give this data to the donors, but the data that we have, like Dr. Tedla said, is flawed or it's not very conclusive, and it can be inferred a bunch of different ways. And there's small studies and et cetera, but it's very difficult. I mean, Victor and Christina's not here, but I mean, they're responsible for obtaining the living donor follow-up, and we follow all of our recipients. We don't send them back to the nephrologist. Most programs send their recipients back to the nephrologist after 6 months or a year. So if you're not even following your recipient, it's really, other than once a year, it's really hard to get information on your donor. So it's very, very difficult to even fulfill those 2 years. And HRSA realized that that was a large gap. And they actually put together a pilot program last year looking at having transplant centers enter a lot more information on the front end about the donors, and then HRSA being responsible for the long-term follow-up with that patient's insurance carrier and other health databases that are beyond my scope. So it would require, right now I know I only know Mount Sinai is participating because a friend of mine is the director of the Living Donor Program there, so she kind of walked me through it, and I saw a presentation. So I know they're a pilot study, and they're going to do for feasibility testing, and I think next year they'll make the determination as to whether or not it's going to go further into other programs, because it's information that is needed, not only for the donors, but for us, but it's very, very difficult to obtain.
That pilot, when eventually they're saying every program should do it and we should have long-term follow-up, it's more a pipe dream. I don't think it would work, and I will tell you why. One is donors are healthy bunch. They are healthy. So if you call them and say, after the second call, they don't even answer your phone call, because why are they bothering me? I'm healthy. Because they're healthy and young, they're going to move around. Today they are in New York, tomorrow they are in Texas, they have found another job there in California. Today's number is not going to work, today's address is not going to work, their doctors change, they may not even have a doctor. So whatever you try, even if says you have to report, we're not going to get data to report. And the other thing is, it doesn't still change the big thing I showed you earlier, that cartoon. The question is not whether somebody among donors would develop something. The question is, could they have developed it with one or two kidneys? And that is an answer, the question that you probably would never answer, because to answer that, you need to have a huge number of people to study. You have to follow them for decades, and nobody is going to do that. So the best chance we have is probably from this 200-ish study on either arm, and that's still about 5 years old. What I showed you, the 3-year, about 2 years ago. And we're waiting maybe another 10 or 15 years before that shows something substantive. And by then, the 200 people probably have dropped out and there are only 80 left. So I don't think we would answer the question any more fully than we have already. But whatever we have, I think, is fairly secure. The problem is, again, the small subsets. If you have a family history of this, what's your problem? If you have borderline blood pressure, what's your problem? If you are obese, those are the ones who are really hard to answer. Anyway, sorry.
Well, thank you all. Does anybody have any questions at all? Thank you so much for your attendance. Sorry it went so late.